Okay, so I hope you can see this. I'm going on full screen mode now. So I hope you can see my PowerPoint on full screen mode.
Yes, doctor, we can see you.
Okay. I'm still waiting for it to go to full screen mode. My computer is a bit slow. Let's hope. All right. So I'm here in the first slide now, and I'm going to talk today on cerebrovascular diseases. Now, as the name suggests, cerebrovascular diseases means diseases of the blood vessels in the brain, in the skull. When I say the brain, I mean in and around the brain, in the skull as well. And the most common cause of cerebrovascular diseases, the most common result of cerebrovascular diseases is hemorrhage. And among various aspects of hemorrhage, we would focus on hemorrhage in and around the brain. Okay. Okay, I move on to the next slide. And what do you guys see here? Anybody?
We're still on the first slide, doctor.
Still in the first slide. All right, hold on. Okay, I've gone on full screen mode and I'm in the first slide now, and I'm now moving to the second slide. And what do you see in the second slide?
We can see Thanos and Iron Man.
Oh, yes. Now, back to the battle between Thanos and Iron Man. If you notice, actually, in the last episode of the Avengers series, Thanos just pushes Iron Man everywhere and throws him around everywhere. But Iron Man actually doesn't get hurt. Okay, Iron Man doesn't really get hurt that much. Tony Stark manages to save himself inside the Iron Man suit. Of course, he had fatal injuries later on. But considering that his head was inside the helmet, why was his head not injured or damaged in any way? Now, the reason is his helmet is made up of a special protective equipment with multiple layers. Now, I move on to the anatomy of Iron Man's helmet. Okay, this is the latest Mark 46 and Mark 50 Iron Man helmets are there, and the latest Iron Man helmets have come out in the Civil War. And if you do a little bit of googling, you'll find that it has 3 layers. And the 3 layers prevent the head from being injured because the head has a nice shock absorptive protective capacity. Now, moving on from Iron Man to actual Formula One racing. I'm moving the slides. I hope it moves in your screens as well.
Yeah.
Yes,
And
doctor.
this is a Formula One, a usual stereotype, typical Formula One racetrack. Now, these drivers drive their cars at full speed of hundreds of kilometers an hour. And if anything goes wrong and if something crashes, these guys get injured. But when you see if it crashes, there's a door that ejects them out and they come running out. Why is it that these people don't get injured? Again, that's because they wear safety equipment and they wear wonderful helmets. Now, these helmets have 3 layers. They have an inner layer and an outer layer which is hard, and a middle layer which has a sort of fibrous protection which makes sure that the head and the skull is intact. The same thing happens in the skull by itself. Beneath the skull, there are several layers: the dura mater, the arachnoid mater, the subarachnoid mater. So these layers make sure that the brain gets protected inside the skull. So as much as I've showed you pictures of imaginary characters until now, I'm going to discuss now what happens when a damage or a breach occurs in any of these 3 layers in the brain. Okay, which is the epidural space, the subdural space, the subarachnoid space, and inside the brain, intracerebral space. Okay, now when any hemorrhage occurs in the brain, it results in a stroke. A stroke is nothing but a manifestation of a hemorrhage where one part of the body becomes weak, or one part of the body undergoes a paralysis, or both legs, or one hand and one leg on each side. Now, as you can see, every year as the age increases, the chances of a stroke increases significantly to the extent that those above 85, 1 in 33% in the population are at a risk of stroke. Now, a stroke or a hemorrhage doesn't occur by itself. It needs some inciting factors, one of which is hypertension. Hypertension weakens the blood vessels all over the body, including the brain. And when it weakens the blood vessels tend to become thin. They tend to swell out. They tend to rupture. Other causes could be congenital, such as in a berry aneurysm. So the first kind of hemorrhage that we are going to talk about today is intracranial hemorrhage, hemorrhage within the cranial vault. The cranium or the skull has an epidural space that is between the skull and the dura mater, the subdural space which is below the dura mater, and the subarachnoid space which is below the subarachnoid mater. So a primary intracranial hemorrhage can be either epidural or subdural or subarachnoid. Sometimes there are a few infarcts in the brain due to certain other reasons, and these infarcts could be due to hypertension or other secondary factors, and these can also result in an intracranial hemorrhage. And when there is a trauma to the brain, it results in intracerebral hemorrhage, which occurs in the parenchyma of the brain tissue. Okay, so we start with epidural hemorrhage. Remember, the dura mater is connected to the periosteum, just like the layers of Iron Man's helmets are connected together. So, when there is any condition where there is a damage to the cranium, the skull, that will cause a fracture of one of the skull bones. The most common bone to get fractured is a temporal bone on the side, because when a person falls, they fall on the side. You rarely tend to fall forward, because when you fall forward, your arms protect you, which is why a person who falls forward, you have a greater tendency to have a fracture of the wrist, Colles fracture, rather than the skull. But when you fall sideways or backwards, there is a fracture of the temporal bone. And the artery that runs along there is the middle meningeal artery. So when it gets ruptured, blood accumulates, the arterial pressure builds up and pushes the dura mater inside from the skull. So a hematoma is formed. This hematoma pushes inside, compresses the brain, and it can cause herniation of the brain from the upper supratentorial to infratentorial space. Very interestingly, in cases of epidural hemorrhage, there is something called a lucid interval, where a person immediately after the injury he feels he is fine. There's no problem. The best example would be a person who's running out of the car after a car crash in a Formula One race. And after he comes out, he says, "Hey, it's okay, I'm perfect, I'm fine," and everybody cheers. But the same thing in boxing, when a boxer gets punched on the face, he seems okay, but after a period of 12 hours or 24 hours, he develops neurological symptoms. This is called a lucid interval, the interval period between the injury and the arrival of symptoms. And this is seen in epidural hemorrhage. Now, this is the skull, dura mater, and blood accumulating between the skull and the dura mater. Yeah. So it pushes the brain inside. So this will cause compression of the brain, damage to the brain tissue, and this can cause herniation of this part of the brain to the lower part. When the skull is opened out, just at the level of the dura, you can see a big hematoma that has formed, and this hematoma is because of an epidural hemorrhage. Once a hemorrhage occurs, in course of time, the blood clots. Okay, so this is what I told you about a couple of slides ago. A lucid interval usually occurs in an epidural hemorrhage or an epidural hematoma. As I mentioned earlier, it is a temporary improvement in the condition. or the consciousness level in a person after being unconscious. Later on, after a period, he develops neurological symptoms. So first there is a concussion, that is an injury to the brain. Then he loses consciousness. Then for a few minutes to hours he is okay. And that is the time when hematoma starts to form, and then his condition declines. And once a hematoma forms, the pressure inside the skull raises. This is called increased intracranial pressure. And there is inflammation. And when there is inflammation, one of the features in inflammation is edema. And this damages the brain. And damage to the brain, if you remember, is always permanent. Brain cells are permanent cells, just like skeletal muscle cells. Now, coming deeper down beneath the dura mater, the subdural hematoma occurs whenever there is an injury to the brain, as in the previous case, or there is a hydrocephalus by which the pressure inside the brain increases, so it pushes out the brain into various aspects and it causes a ventricular decompression. The person may be on anticoagulant therapy, as a result of which blood clots don't get formed and bleeding occurs. Or the person could have thrombocytopenia, as a result of which the person is unable to form clots and there is bleeding. Or when a lumbar puncture is done, and a lumbar puncture, if you realize, a lumbar puncture at a level in the lower spine is still connected to the cerebrospinal fluid, which is beneath the dura mater. And a bleeding there can actually go up and accumulate as bleeding in this subdural space in the brain as well. So just beneath the level of the dura mater, you have the bridging veins. These are the veins that connect various aspects of the dura mater together. Now these bridging veins rupture very easily. Remember, they are veins and not arteries. Arteries have thicker walls, veins have thinner walls. Or damage to the cortical arteries. Either way, there is a collection of blood which accumulates between the dura mater and the arachnoid mater. And this blood spreads all over the surface of the brain. And when it accumulates, it pressurizes the brain to push inside and it flattens the brain. But there is no bleeding inside the brain. The bleeding occurs between the skull and the brain. So as blood accumulates, the pressure in the brain causes symptoms, which is unconsciousness and later on coma and death. So what are the symptoms of a subdural hematoma? The patients manifest with headache. Again, all these are because of pressure symptoms. Nausea, confusion, personality changes. And as his consciousness reduces, he is unable to open his eyes. His speech gets slurred. And pressure on the optic nerves will cause impaired vision. And pressure on the internal capsule or any part of the inner part of the brain, the corpus stratum, the genu, all that will cause paralysis of one side of the body. So this is the dura mater, and until the previous slide, I actually showed you that the blood accumulates between the skull and the dura mater. Here, the blood accumulates beneath the dura mater. So this is a subdural hematoma. Now this is a CT scan that shows a subdural hematoma, which has accumulated beneath the dura mater and it has pushed the brain onto one side, so much so that you can see that the lateral ventricle is totally compressed on one side and it is pushing towards the other side. Now here is a comparison between an epidural and a subdural hematoma. On the left side is an epidural hematoma. You can see that the dura is pushed in and it compresses the brain. And there's blood accumulated between the skull and the dura mater. The most common cause for this is usually a skull fracture, such as rupture of the middle meningeal artery. The blood accumulated is arterial blood. While in a subdural hematoma, the dura is still attached to the skull. While Venous blood tends to accumulate because it is the bridging veins that are damaged more, while here it is the middle meningeal artery that is ruptured. But yet, in both cases, the brain tends to get compressed. Now, here is a gross post-mortem autopsy specimen of a brain that has been cut open. It is compressed because of blood that has accumulated beneath the dura mater. This is the dura mater, and the blood is accumulated beneath the dura mater. So, what happens when blood accumulates beneath the dura mater? A clot is formed. Any clot that is formed has to undergo lysis, and this clot starts lysing in a week. And in a couple of weeks, if you remember the earlier sessions on granulation tissue and healing, one of the aspects of healing is formation of granulation tissue, where fibroblasts are formed, angiogenesis occurs. So that's what happens in this case. And in a couple of months, the entire area becomes hyalinized. So the clot tends to get removed. But this can undergo complications. The patient can have repeated bleeding, which can result in chronic subdural hematoma, where this could occur in conditions when he has thrombocytopenia, or is suffering from any bleeding disorders, or on anticoagulant therapy. The pressure of the blood on this hemisphere can cause the brain to pressurize on the other side, and it can affect the adjacent hemisphere. The pressure can cause a hydrocephalus, and the brain compression can result in dementia and epilepsy and convulsions as well. If the person survives later on, he is prone to developing a benign tumor of the skull, which is benign tumor of the meninges, which is a meningioma. And the brain can undergo either a subfalse herniation or a transtentorial herniation. A subfalse herniation is when the brain herniates from the left side to the right or the right side to the left. That is, the contents from the third ventricle, lateral ventricle, push over to the other side, just as I showed you in the CT scan a few slides earlier. Transtentorial is when a part of the supratentorial brain pushes down into the infratentorial space. The third aspect of hemorrhage is subarachnoid hemorrhage. Now, this occurs due to various causes, most commonly due to hypertension, and then trauma, and then due to tumors and hematological disorders. But as far as medicine is concerned, and exams are concerned, and questions are concerned, you need to know that it could be due to a rupture of a berry aneurysm, which is most commonly in the arterial circle of Villus. Now, arterial circle of Villus is something that you guys would have done in the anatomy. Now, this is what it is. It is a circle that is formed at the base of the brain, with the basilar artery below, the posterior cerebral arteries, the middle cerebral arteries, the internal carotid artery. The posterior cerebral communicates with the middle cerebral with the posterior communicating artery, the anterior cerebral arteries, and the anterior communicating artery. A group of this cluster forms the arterial circle of Villus. Now, the most common locations for berry aneurysms are at the junction of the anterior communicating artery and the anterior cerebral artery, the middle cerebral artery, between the middle cerebral and internal carotid, and the posterior cerebral. Now, berry aneurysms are saccular aneurysms, unlike fusiform aneurysms. If you remembered your cardiovascular lectures, you would realize that fusiform aneurysms are more sac-like, are more radish shaped. They're more elongated, and they're usually seen in the descending abdominal, in the descending aorta and in the abdominal aorta. While berry aneurysm are more sac-like, and usually occurs when there's an increased intracranial pressure. Believe me, an increased intracranial pressure can occur even with something as simple as straining while passing motions. And added to these are risk factors like smoking, hypertension, and the patient is on anticoagulant therapy. Okay, so these are the common sites of cerebral aneurysms due to perianeurysms, which I just explained in the previous slide. And here is a picture taken from a postmortem specimen that shows hemorrhage due to multiple aneurysms along the arterial circle of Villus. And you can see clots formed here as well. So from a berry aneurysm, the blood ruptures, the blood passes through into the subarachnoid space and the cerebrospinal fluid. If you remember, if you may recall, cerebrospinal fluid is a clear fluid, but it can get turbid and red because of the RBCs and it can become pink. So this RBCs have to be removed. So they are removed by the macrophages in the system. So when they are removed by the macrophages in the system, the macrophages become red and brown because they get laden by hemosiderin when they eat up the RBCs. Very similar to the hemosiderin laden macrophages in the lungs, which you see in heart failure when there is pulmonary edema. So, when there is a rupture of a berry aneurysms, patients present with severe excruciating headache and can go on to loss of consciousness and sudden death. Now, how do you diagnose? One form of diagnosis is an MRI, where you can actually see the berry aneurysms or the aneurysm that has ruptured or the bleeding that has occurred in and around the place. And the other is to tap into the cerebrospinal fluid. You will find that it is pink in color. We call this xanthochromic because of the accumulation of RBCs. The CSF is blood tinged or blood stained or pink in color. So subarachnoid hemorrhage, remember, is different from subdural or in the other forms of hemorrhage that occur beneath the skull, below the dura mater. Here, it moves down, pressurizes the brain, causes hydrocephalus. It can cause rebleeding from the aneurysm. Later on, it can cause ischemia in the brain because there is a loss of blood supply in the brain because all the blood vessels are bleeding. So there is no blood to nourish the brain. And these people can go on into epilepsy. If they recover, they would later on go on with cognitive dysfunctions in difficulty in performing tasks or inability to concentrate or other emotional disorders. This occurs after these people have recovered after a long period of time, considering that they have had a good prognosis when it comes to recovery. Okay, so until now, all this while we've actually discussed about hemorrhages, not inside the brain but outside the brain. Okay, let's have a quick recap of what we've done until now. We've actually spoken about we started with talking about Iron Man's helmet and about how protective his helmet is because it's got several layers. And the same thing inside our skull. The skull has several layers in the sense that it has the meninges inside, and the meninges are multi-layered. The dura mater, the arachnoid matter, the subarachnoid space, and the pia mater, of course, as a result of which the brain is protected from all forms of injuries. However, despite this, if you're careless and injuries occur, it could be an intracranial hemorrhage, which is either epidural or subdural or subarachnoid. These are primary intracranial hemorrhages which we have seen so far. Okay. You also discussed about lucid interval, and now we move on to intracerebral hemorrhage. I hope you guys are with me now so far. I will continue with the rest of the session. Okay, I've gone back to screen presenting mode. I hope you can see the screen. Intracerebral hemorrhage. Are you with me? Okay, are you with me so far, guys? Can I hear anybody say
Yep.
yes?
Yep.
Yes, doctor.
Yes,
Okay,
doctor.
thank you. Not bad. Thank you so much. I hear a lot of voices, which shows that you guys are still awake. Thank you very much. We now move on to intracerebral hemorrhage, which is hemorrhage inside the brain. This would occur when there is an extravasation of blood into the parenchyma. Now, how can you get bleeding into the brain? Now, from outside, from the dura mater, blood will not actually create a channel and go into any parenchyma in the brain. It can occur only when the bleeding starts inside the brain, such as near the ventricles or the subarachnoid space. And this is one of the causes of strokes and occurs in the elderly. Now, what causes this? A rupture of any blood vessels. And rupture of blood vessels occurs when blood vessels are weak. When do they get weak? When there is hypertension. And when there is hypertension, what happens to the blood vessels? They are narrowed and thick due to atherosclerosis. So, the same atherosclerosis that causes coronary artery thrombosis, that causes coronary artery narrowing, that causes coronary artery ischemia, can cause rupture in the brain and lead to hemorrhage. Aneurysms, disorders of coagulation, any vasculitis where the blood vessels are thickened, and because of thickening and inflammation, there are numerous forms of vasculitis such as polyarteritis nodosa, vaginous granulomatosis, giant cell arteritis, systemic lupus erythematosus, Goodpasture syndrome. Not many affect the brain, but vasculitis can affect the brain as well. Amyloidosis also presents like vasculitis. The blood vessels are thickened with accumulation of amyloid, or any tumors that is pressing near a blood vessel can cause a rupture of the blood vessel. So when the blood accumulates, it damages the entire brain structure, the architecture, due to increased pressure and mechanical damage. If the person recovers, the hematoma may increase in size, or the ventricle may be compressed, and that can cause an irreversible neurovascular disruption. Bleeding occurs in the brain, but the brain tissue does not have blood for nourishment, as I said earlier, and that can cause brain edema and necrosis. And necrosis is permanent, it is not reversible. So, what happens when bleeding occurs inside the brain tissue or inside the parenchyma of the brain? RBCs start undergoing lysis within the first 1 or 2 days, and they release hemoglobin. Now, hemoglobin inside the brain is considered cytotoxic because it contains heme, it contains iron, it contains free radicals. These have to be scavenged. We don't have scavengers. We don't have antioxidants in the brain except for macrophages that start coming in. So, this will release toxic agents and that will cause damage to the brain cells. So, when a hematoma occurs or a hemorrhage occurs, the blood in the hemorrhage irritates the brain tissue. That damages the neuronal tissue and the supporting tissue. The supporting tissue is the glial tissue. So the brain swells up. Why? Because of edema. Edema is a feature that you see in any form of an inflammation, which is an exudate in other parts of the body. So to remove these RBCs, macrophages come inside. Astrocytes start becoming reactive. Astrocytes are the supporting cells like macrophages that help in healing. The edema causes an increased pressure in the brain. As much as all this occurs, the brain by itself cannot function because its blood flow is reduced because bleeding is occurring in other places. So there is necrosis. Now here is a gross picture of a slice of a brain which shows a large area of liquefactive necrosis with bleeding as well. Now if you may recall, the type of necrosis in the brain is liquefactive necrosis. The type of necrosis in other parts of the body is coagulative necrosis. Now liquefactive occurs in the brain because the brain is already semi-solid and semi-liquid. Okay? While remember, coagulative necrosis occurs more in solid organs such as the heart, the lungs, the liver, the kidneys. And when a coagulative necrosis occurs due to tuberculosis in the lung, it becomes caseous necrosis. In the brain, it is liquefactive. For that matter, when you have a patient with gangrene of the limb, where necrosis starts off with coagulative, when bacterial or fungal infection sets in, it becomes liquefactive. Another slice of the brain that shows an old area of an infarct that has undergone liquefactive necrosis. When an infarction occurs, when a part of the brain dies, the brain first becomes soft. Within 1 week, there is inflammation. Within the second week, there is neovascularization. If you remember, that is part of healing. Neovascularization, granulation tissue formation, fibroblast formation, monocytes coming in and turning into macrophages and phagocytes. And after the second month, astrocytes start proliferation. Scarring occurs. Scarring is a process of healing, which is why anywhere in the body, when you get a cut, the place leaves a scar. The same thing happens in the brain. But in the brain, neurons cannot regenerate. So the dead tissue that is dead remains dead forever. It is only the remaining brain tissue that can start functioning normally. Now you may ask me, why is it that after a person has developed a stroke on one side, after a hemorrhage in the brain, is able to walk again after a few months? That is because that is not because the brain tissue that is dead has started proliferating again. That is because the surrounding brain tissue wakes up to the occasion and tries to compensate and performs the function of the dead tissue. So, what are the sequelae of an infarction? What happens a few weeks or months or years after infarction or a hemorrhage? The person always remains with neurological deficits because of blood blood not having been there at that time. So there are small areas in the brain that have died. And in the case of hypertension and diabetes, these infarcts are like small pools or lakes. We call these lacunar. Lacunar means lake, a lake-like infarction. And in some cases, these infarcts will be preceded by a TIA, also called transient ischemic attack, where a person develops very mild symptoms that last only for 24 hours. And one thing I mentioned all this while is edema. When there is edema, there is accumulation of chemical mediators. And all these chemical mediators will try to hasten the process of inflammation. And then there is liquefactive necrosis. And the brain can herniate through the foramen magnum into the spinal cord, and that can cause death. Now, edema is something that I've been mentioning all through in the past 30-40 minutes. Remember that there are numerous causes of edema other than what we've discussed today. It could be to any other form, ischemic stroke, cancers in the brain, inflammation in the meninges, or a person going into high altitude very rapidly and then he cannot acclimatize and there can be an edema. Symptoms of cerebral edema are the same as symptoms in a cerebral bleeding because in both cases there is fluid accumulation in the brain. Three slides ago, I mentioned about TIA or transient ischemic attack. What is a TIA? A TIA is nothing but a mini stroke. A person feels that he has got a stroke, but he feels weakness on one side of the body, but it is not a total stroke. It is a warning of an impending stroke. It could probably mean there is a clot in the cerebral artery. TIA usually is transient and the person recovers within a few minutes, while a stroke is a permanent blockage and that results in brain damage. Risk factors of stroke and TIA: people with family history, elderly people, males have a higher risk of TIA, people with hypertension, diabetes, smoking, and those who have a history of headaches. And anybody with a history of TIA also goes on to have a strong history for a stroke. But remember, some strokes are preceded by a TIA, majority of the strokes are not preceded by a TIA. A TIA, a transient ischemic attack, resolves by itself before brain damage. and it does not cause any permanent injury to the brain. Okay, so this is the last part of my session where I talk about contractile hematoma, where you can see that the patient has bleeding here in the frontal and the temporal region. Okay, can I ask one of you, where do you think this guy would have got injured? Here or here? Anybody? Can you take a guess?
The upper one?
You mean this side?
Yeah.
Okay, that was my last slide anyway. I finished with a very interesting aspect called contractile hematoma or contractile injury. Contractile injury is a form of injury which occurs when you get an injury on the opposite side of where you had the impact. Now I go back to the very first few slides where I showed you a picture of a Formula One racer. When he crashes into another car, the head moves forward with a jerk. So theoretically, the brain hits the dura mater in front and you're supposed to get injured in front, but it doesn't happen that way. It goes forward and lashes back. And when it lashes back, it is the rear of the brain that gets injured. The same thing, when a person is pushed back, you push back and come forward, the brain hits the front. This is called contractile on the opposite side. Injury that occurs on the opposite side of the impact is called a contractile injury. Okay, so I finished with that. In the second half of the session, we actually spoke about a quick summary. We spoke about intracerebral hemorrhage, that is hemorrhage inside the brain, and we went into the various etiological factors and the pathophysiology. Now, we also went a little bit into liquefactive necrosis, and I also discussed about infarcts and edema. Remember, features in edema are the same as features in hemorrhage, just that hemorrhage is blood, edema may be due to blood and liquid as well, and it will produce the same kind of symptoms. And we finished off the session with a few words on TIA, transient ischemic attack, and how a TIA can actually herald or give you an indication that a TIA can result in a stroke later on. Okay, so with these few words, I finish the session and I open the session for any questions, discussions. You may choose to text in the text box or you may choose to ask me questions. Okay, if there are no questions, I understand that you may have a few questions after going through my lecture once again on your earpods or on your desktop. So at that point in time, if you have any questions to ask me, please feel free to PM me either by email or on my WhatsApp number as well. And if I'm not able to respond immediately, I'll call you by the end of the day and explain. Okay, thank you very much and have a nice day.
Thank you,
Thank you,
doctor.
doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.